There is surprisingly little existing information out there to teach you strategies for communicating effectively in a discussion about a person's goals of care. Again, there's no single right way to go about it, and every patient's situation is unique. Regardless of how you approach the topic, remember that it should always be handled sensitively and provide accurate information. The literature tells us that patients prefer the discussion to be honest, at a slow pace, and using clear language. Some authors suggest the use of an opening question, such as, do you want to talk about the kinds of treatment you would like if you became very ill? This helps us to gauge how much an individual wants to know and to what extent they prefer to be involved in the decision-making process. After broaching the topic, the majority of discussions about resuscitation status will include the following key elements: a review of the patient's diagnosis and prognosis, based both on current illness and comorbid disease, an explanation of what resuscitation is and in what situations it would become relevant. This usually involves an overview of what CPR consists of, i.e. chest compressions, intravenous drugs, intubation and mechanical ventilation, and electrical shocks. It should also include an exploration of the patient's own attitudes and values on the subject, and a clarification of the possible and probable outcomes of any given course of action, i.e., what are the chances that a resuscitation would be successful. It should always include an opportunity for questions and discussion. Often, a discussion about resuscitation status fits nicely into a bigger discussion about the patient's goals of care. These give us a framework to guide us in the matters of where are we going and what does this patient hope to achieve. Although we are taught in our medical training to try to cure and to save lives, there are other potential goals that might be better suited to a given person's situation. These could include curing illness, living longer, improving current health or maintaining current health, being comfortable, or possibly achieving a specific goal in life. Like code status, goals of care are very individualized. They're based on a person's given clinical situation and personal values. One patient may have multiple goals of care. Clearly establishing a patient's goals of care can be very helpful in establishing their resuscitation status also. For instance, in a terminally ill patient whose primary concern is being comfortable, a DNR status would be the most consistent with their goals. But by contrast, a middle-aged patient with potentially reversible disease would most often elect for a full code status. Having the discussion about resuscitation status and goals of care is only the first step. The conclusions you reach are only as good as your ability to communicate them to the rest of the team. Some facilities have pre-printed orders for documenting an inpatient's resuscitation status, but in the absence of such a form, at minimum, you must always clearly write instructions in the physician's orders section, as well as a note about the discussion in the progress notes of the patient chart. It is not enough just to write DNR. You should always spell out exactly which interventions you've discussed with the patient. For example, you might write, in the event of cardiorespiratory arrest, no intubation, no CPR, no defibrillation, but the patient would accept a short trial of BiPAP if necessary. It is also helpful if you communicate this verbally to the nursing staff and other allied healthcare professionals involved in the patient's care. Having a discussion about a given patient's values can be an important opportunity for them to express their wishes to their loved one. I always make a point to encourage my patients to talk openly with their loved ones about these issues. There are many misconceptions about resuscitation and discussing it. Let's address a few of these now. Myth number 1, talking about resuscitation is upsetting to patients. In fact, surveys have shown that the majority of patients are comfortable discussing resuscitation with their doctors. One study found that only 1 out of 100 patients became upset by the discussion. When it's handled appropriately, a code status discussion can actually be a very positive experience for patients and makes them feel that their values and opinions are heard. Myth number 2, patients will initiate code status discussions themselves. Although most patients indicate that they do wish to be involved in the decision-making process, the literature shows us that only a very small proportion would spontaneously disclose their preferences about CPR. And myth number 3, CPR is often successful. Hollywood gives us a false sense of how successful CPR is. Studies say that on average, patients guess its success rate to exceed 50%, but the literature tells us that on average, only 10 to 20% of inpatients who undergo CPR survive to hospital discharge, and only 14% of inpatients who undergo CPR would maintain good neurologic status afterwards. Myth number 4, we must offer full resuscitative measures to every patient. Actually, as physicians, we are not obligated to offer any treatment measure deemed to be futile or non-beneficial. In the case of a patient who would almost certainly not benefit from CPR, it should not even be presented as a treatment option. Ideally, this decision would be communicated to the patient and their family. And finally, myth number 5, DNR means do not treat. Actually, a DNR order only gives instructions about CPR and nothing more. A decision against CPR does not preclude a person from receiving full medical management up to the point of arrest, or from being actively palliated as the situation dictates. It is really important to communicate this clearly to your patients, who may perceive that if they don't opt to, quote-unquote, do everything, i.e. to pursue a full code, that they might be defaulting to doing nothing. Obviously, this is not the case. We've covered a lot of material here, but let's review some key concepts from this video. First, I hope you've now gained an appreciation for just how essential well-led discussions about goals of care and resuscitation are to good patient care. As such, it is key that they become a part of your routine practice. Remember that we as physicians are often the biggest barriers to these discussions, and we can often be more anxious about having them than our patients are. A well-led code status discussion is clear, honest, and delivers accurate information to the patient and their loved ones. And finally, remember that the discussion itself is only the first step. Document all code status and goals of care discussions clearly and completely. I hope that this has inspired you to go out and explore some other resources on the topic. Here are some of the articles that I found to be particularly helpful.